Okay, I guess I'll start with this. Impaired bilirubin. Impaired bilirubin, we end up with jaundice, right? Because we're not able to excrete that. So the types, we have hemolytic or prehepatic jaundice. So that's when we have excess red blood cell destruction. And the liver can't process that because, again, the liver helps with the breakdown and excretion of those red blood cells. Okay? Now, you see this in babies, right? We're going to talk about this a lot in 2030 in spring semester. Okay, so some people with babies, have you ever heard of where they have, they wait until the umbilical cord stops pulsating, get all that extra blood volume into baby? So that can be a good thing, right? We want baby to have excess blood volume, but if they have too much blood volume, they're going to break down a lot more of those red blood cells through the liver is going to be overwhelmed, and then you're going to end up with jaundice. Okay, so that's one risk that is associated with, waiting to clamp the umbilical cord when a baby's born. That's a good example of your hemolytic, right? High unconjugated bilirubin, that can also cause your jaundice, right? So think back to the slide before. So we also have hepatic, so impaired liver cells, like we talked about. We can't convert and excrete. You will see dark urine in these cases because we're not able to excrete the bilirubin. And then obstructive bilirubin and jaundice is after we get out of the liver. Okay, so that's the obstruction of your bile flow. Okay, from the gallbladder and those bile ducts. Okay, the stool is going to have some changes in your post-hepatic. Your stool may be more light in color, okay, because there's a lack of bilirubin, or maybe dark urine. Has anyone seen anyone with impaired liver function and their urine's extremely dark?
I have the light stools, that's how she knows.
Yeah, so you know that there's an issue with the bile, right? And the bilirubin because your stools are very different. That. Okay, so here's some pictures. Okay, so you can see some jaundice. A lot of times you can see jaundice start within the whites of the eyes, right? Sometimes I'll watch people on TV and I'm like, oh, their liver's okay, right? Because that's some of the first things that you see. It's like those neon white bright eyes. Okay. Disrupted blood flow. So we term this typically by your portal hypertension, and we're going to spend quite a bit of time on this. So your portal venous system, we use that to drain your GI tract, spleen, and those surface veins within the abdomen. Okay. Portal hypertension is where we have that increased pressure within the portal system, and I have a picture of that too. Okay, but what happens is your veins begin to dilate and there's congestion, okay, because of that increased pressure. So if we have pressure on the venous system, is it going to be able to pump effectively, or is blood going to be able to move how we need it to? No. So then we're also going to see the spleen start to enlarge. Okay, fluid in the peritoneal cavity, so ascites. Okay, you might see low albumin levels. Okay. Then you may move into this hepatorenal syndrome, which is acute kidney failure as a result. And then moving into hepatic encephalopathy, which we're actually going to spend a lot of time. Hepatic encephalopathy, you know when your patient is going into this, okay? It's going to be an acute change from baseline with mental status. So impaired consciousness, okay? One day they're going to be able to talk to you, talk to their family, like there's nothing wrong. The next day, they're not even going to know who they are, right? So it's a very quick shift, okay? And it's caused from increased buildup of ammonia with. Okay. This can eventually lead to cerebral edema, which is very dangerous. Okay. So if we have disrupted blood flow and portal hypertension, it can lead to all these different problems that can occur. Portal hypertension. So what are we going to do? And how are we going to treat that? I'm going to see if this is okay.
Drinking warm water before bed balances blood sugar levels and reverses type 2. Thousands of
The liver is the primary filter between blood returning from the digestive tract, which can carry nutrients, minerals, amino acids, drugs, and anything else we consume, and the systemic circulation. So what happens when this filter is obstructed? Blood is supplied to the digestive system from 3 branches of the abdominal aorta, the celiac trunk, and the superior and inferior mesenteric arteries. Various substances enter the bloodstream through the GI epithelium. Then, from the lower esophagus to the upper colon, blood drains from the digestive tract into the splenic, gastric, and mesenteric veins, all of which combine to form a single hepatic portal vein that goes to the liver. The functional unit of the liver is the hepatic globule. Here, blood flows from small branches of the hepatic portal vein through sinusoids lined with hepatocytes. These specialized cells detoxify blood as it passes to the central vein in each lobule before returning to systemic circulation via the hepatic vein. Portal hypertension refers to increased hydrostatic pressure in the hepatic portal vein and is typically caused by changes within the liver itself. These changes may include blood clots, tumors, and parasitic infections. But in Western countries, cirrhosis is the condition most commonly associated with portal hypertension. Cirrhosis refers to widespread scarring of the liver and can be caused by long-term alcohol abuse, viruses such as hepatitis C and B, certain drugs, advanced fatty liver disease, or excess iron intake. Around a liter of blood flows into the liver from the portal vein every minute. As pressure increases, blood flow is rerouted to areas of anastomosis between the systemic and portal circulatory systems, which can lead to varices, or distended vessels that can easily rupture and cause excessive bleeding.
Okay, so varices, has anyone seen anyone with esophageal varices, right? The big thing we start to see when we have, end-stage liver cirrhosis, liver disease, whatever it may be, right? So it can be very dangerous, and it's not just in your GI tract, right? But it can also happen in your esophagus.
Varices occur most often at the lower esophagus, rectum, and umbilicus. Without the detoxifying effects of the liver, blood that circulates back to the body contains nitrogenous waste products, primarily ammonia. These substances pass into the brain, resulting in hepatic encephalopathy, altered consciousness, changes in mood and personality, mobility issues, and in some cases, coma. Portal hypertension also causes increased pressure in the splenic vein. While not as likely to rupture, this backup causes splenomegaly, leading to a reduction in blood components, including red blood cells, which causes anemia, white blood cells, leading to increased risk of infection, and platelets, which can exacerbate any bleeding. The increased pressure in hepatic sinusoids and the splanchnic bed also leads to ascites, or excess fluid in the peritoneal cavity. Treatments for portal hypertension vary depending on the underlying cause. Some conditions, such as schistosomiasis, can be cured with drugs, while others, like cirrhosis, are indicative of end-stage liver disease and require a liver transplant. More often, the goal of therapy is to manage the sequelae, the effects of portal hypertension. Varices can be treated endoscopically, either by banding or injection of a sclerosing agent. Hepatic encephalopathy is treated pharmaceutically by lactulose, which draws ammonia into the large intestine so that it can be excreted in stool. Ascites is managed by dietary restrictions and medications, and severe cases can be treated with paracentesis, the drainage of excess fluid using a sterile needle inserted into the peritoneal cavity. Beta blockers are used to increase vasoconstriction in the gut, thus reducing splanchnic bed outflow and decreasing pressure in the portal vein. For severe portal hypertension, a transjugular intrahepatic portosystemic shunt, or TIPS procedure, can relieve pressure. This procedure involves forming a mesh-enforced channel within the liver to allow blood to return to the systemic circulation via the hepatic vein. As with the other collateral pathways, blood that hasn't been filtered by the liver can carry ammonia and other toxins, and hepatic encephalopathy is a significant post-treatment risk.
So if we kind of bypass the liver, right, it helps with the pressure buildup, right, within the abdomen, it helps with that portal hypertension, but we're still not filtering blood effectively, so we still may end up with those levels of ammonia buildup and things like that, that can still cause some of those neuro changes, right? But hopefully, if we decrease that portal hypertension, we can decrease some of those other side effects. So it's not necessarily a win-win either way, but we may need to, weigh the risks and benefits of both.
In short, the hepatic portal system routes blood from the digestive tract through the liver to protect our bodies from any dangerous substances that may be absorbed by the intestines. Increased pressure in the portal vein can lead to life-threatening varices, hepatic encephalopathy, splenomegaly, and ascites. Various medical interventions can help manage these symptoms, and a shunt can relieve pressure in the portal vein. But for certain underlying conditions like cirrhosis, a liver transplant is the only long-term treatment for portal hypertension, underscoring the importance of addressing lifestyle choices that may lead to severe and irreversible liver damage.
So does that animation kind of help put all the pieces together a little bit better than just me talking to you about it, right? But it is a very good summary of those things. So we're going to switch over to hepatitis. Okay. Hepatitis in itself is the inflammation of those liver cells. Okay. We talked about it. If your liver cells are not functioning, right, you're going to end up with some issues as a result of that, right? Because we're going to have damage to the cells that are excreting some of those wastes from our body and help with liver function. Okay. With hepatitis, it can be acute or chronic. Okay, viral hepatitis is actually your most common. Okay, we also have toxic and drug-induced. Okay, so exposure to alcohol, acetaminophen, drugs. Right? Has everyone heard of like Tylenol overdoses? Right. Secondary to other viral infections, herpes, Epstein-Barr, varicella, or CMV. Does anyone know the other term for that one? We'll talk about a lot next semester. Cytomegalovirus, right? And direct infection from another person. Okay, the infected person may not know they're infected with hepatitis. Okay, this is why we use standard precautions in the hospital, right? Or if you know someone has hepatitis, you can get that from them, so we make sure that we're, not in contact with those bodies. Okay. There is a pattern of the infection process with hepatitis. So incubation period, we call that the post-icteric, after exposure. Okay, so think about anytime you get some sort of virus or infection, right? You have the incubation period. You might have abrupt symptoms, or they can be insidious, so they kind of develop over some time. You're gonna see things like flu-like symptoms, nausea, vomiting, diarrhea. Right upper quadrant pain. Why right upper quadrant? Where your liver is, right? Your liver's not happy when they're, in this pre-incubation period already. And then fever and chills. So your body knows that something's not quite right. Okay. Then it moves into the icteric portion, which is where you start to see some jaundice. Okay. 5 to 10 days after you start to have symptoms. Okay. So again, yellow skin, looking at the sclera, the mucous membranes, okay? Dark urine, light stool, all the things we talked about with our jaundice, and then itching, okay? The buildup of bile and things like that in the body, itches very, very badly. You see this in hepatitis A and B, but we actually do not see this in hepatitis C, so that's your main difference there, okay? The fever will eventually resolve, appetite will increase, and the physical symptoms will start to resolve, but we do see the jaundice. Okay. And then we're going to go into a recovery phase, or the post-icteric, beginning after the jaundice has resolved. Okay. So the function of our liver is starting to resolve at this point, right? Does that make sense to everybody? So that may, the resolution period may last up to several weeks. Not sure, it depends on the person, and they're going to gradually start to improve. Okay. Does everyone understand the pattern so far? Okay. Now we're going to compare the types, and this is where people struggle probably the most with the pattern. Okay, but your book has a really nice table on the comparison of different types. Okay. And there are also videos online you can look at as well, just make sure that they're clear, right? But hepatitis A, HAV, hepatitis A virus, is fecal to oral. Okay, so you come in contact with someone who has hepatitis A in their feces and you somehow ingest it. Where do you think this happens most? That food, food industry, right? So people not washing their hands after they go to the bathroom, yikes, right? This is why it's so important for public health that we are teaching this at a very young age. Wash your hands. Okay, if you work in food service, wash your hands. Okay. So contaminated food and water sources, this happens a lot in underdeveloped countries. Okay, they don't have the capabilities we have to filter their water and make sure that it's safe for consumption. Okay, and close contact with an infected person. Okay, hepatitis B, think blood. Okay, this comes from sexual contacts from mother to newborn, or any type of contact with blood. So you see this in IV drug users sometimes, right? Because they may be sharing needles. Okay. So any of those things. Okay. C also with blood, right? And this one I say you see most common. Okay, a little bit more so than your hepatitis B. Hepatitis C, a lot of times you see this in your substance abuse. Has anyone seen hepatitis C on the unit for behavioral health? Okay, sometimes hepatitis B as well, but those are your two most common you're gonna see there. Contact with blood or organ transplants, tattoos, or sexual contact. Contact. So again, tattoos, if you're getting tattoos at your friend's basement, you know, he's trying to save a few bucks, not getting a new needle, yikes, right? We might get risky. Okay. And then hepatitis D, infection with the HBV virus. Okay, so mostly you're gonna see this one in your mother newborn cases. Okay. And then E is also fecal oral, so I need you to remember both A and E are your fecal oral drugs. Okay, and you can get that from contaminated food and water. Less commonly with your close contact. A, you can get that. It's a little more, when we talk about virility, the viral capacity, A is has a little higher. So close contact.
B and C are the most common, correct?
B and C you probably see most often in the healthcare industry, yes. They're gonna cause more severe symptoms. Blood testing. Because a lot of the symptoms are gonna be similar. We're gonna talk about that too. So important information. So hepatitis A, your primary risk is gonna be that international travel. Okay, because in the United States, we've done a good job of filtering our food, or filtering our water, I apologize. And then also making sure that our food practices are safe. Some of those things aren't, you know, as effective in other countries. So that's where you get your primary risk. The virus in the stool, right, so with your fecal oral, can be in your stool for up to 2 weeks before you start to see symptoms, or after exposure. Okay. And with A, abrupt onset can last 2 months. So for 2 months, we need to be really careful, right, with preventing transmission. And then typically, again, the symptoms are gonna be more benign and self-limiting compared to your hepatitis B or C. Is everyone with me so far? Okay. Hepatitis B, you're gonna have 3 distinct phases. Okay. The timing does depend on the immune status of the person who's infected. Okay, so if you have lower immune function, you may start to see symptoms a little bit more quickly. Okay. There's a risk for liver cancer, failure, or cirrhosis with hepatitis B. So do you see why that one's a little more worrisome? Again, right? So it can lead to kind of those more insidious disease processes. Okay. Once the immune system fails, the virus is going to directly attack the liver. This is why you may end up with things like cirrhosis over time. Okay. The liver cells, you're going to end up with that hepatocellular failure. The liver cells become damaged, right? So think back to what we talked about before and the things you're going to start to see. Okay. Hep C, without treatment, this typically cause progressive liver disease. Okay. Hep C is a little more common than Hep B. Okay. Again, injection drug use is your primary risk factor. There are universal screenings we have in place, right? So sometimes when patients are admitted into the hospital, if they have riskier behaviors, they're gonna be screened, right, for hepatitis C. And pretty much all of my patients on behavioral get screened. Because they engage in risky behaviors, right? We talked about that. Again, we may test more frequently if there are those risk factors, and then most are going to be diagnosed after that long-term exposure when they start to develop some of those other symptoms. So this one stays with you for a long, long time. Okay. I think that's the big one, if I think about it. So hepatitis A cases decreased during 2021. Okay. Also, your hepatitis B cases decreased during 2021, but hepatitis C were more on the rise at that time. So there is, you can look at this link and see some more statistics there as well. Yeah, show you the hep C videos.
C is a major problem in the United States and really around the world.
More people are dying of hepatitis C in this country than in China. I think many people don't hear about what hepatitis C even is and how you can get it. So hepatitis C is just a virus. It doesn't do a whole lot other than want to live in your liver and make more copies of itself. So the word hepatitis has to do with hepa, which is the liver, anything having to do with the liver, itis, which means irritated or diseased. And we know that there are different viruses that once they're in the body, their home base is the liver. The primary viruses we see in this country are hepatitis A, hepatitis B, and hepatitis C.
So anytime someone's exposed to someone else's blood, and that could happen through blood transfusions before 92, organ transplantation before screening, people on dialysis, people with hemophilia, as well as people who inject drugs. All were identified as high-risk populations, and it's where people live with HIV, because many of the same modes of transmission for HIV are also true for hepatitis C. Their immune system tries to fight it, and this battle goes on in a very silent way in their liver for 10, 20, 30, 40 years. And it may also be causing other problems. Hepatitis C is linked to things like the development of type 2 diabetes, as well as lymphomas and kidney disease. But what happens to some people is over time, their livers scar, leading to cirrhosis. But it's only at that stage when the liver can no longer function that symptoms become obvious.
When you're having all that itching, that's because your liver was acting up.
It didn't affect anything that I was doing. So I didn't respond to it.
And once you get cirrhosis, your liver can stop working.
And the idea is if you don't know you have it, you can't get the treatment and you can't be cured.
Interesting. So what things are we going to see and how are we going to diagnose this? Your ALT. Okay, so that's your enzyme that's released when you have liver damage. Your AST also is going to elevate, right?
This is for all types of hepatitis.
Yes, yeah, because it's all causing some of the same thing, right? Your liver inflammation and damage to the cells, right? ALP, okay, so this one you see a little bit after the AST and the ALT return to normal. So this one takes a little bit longer before you start to see that change. Okay, bilirubin, you're gonna see bilirubin build up, right? Because the liver's not functioning. Okay. And they can actually test for the conjugated and unconjugated that we talked about. Okay. Again, they're going to check for the virus via that viral antibody and antigen testing. And then to make sure, to make a definitive diagnosis, they may end up doing that biopsy as well. Okay. The liver biopsy is really good at telling the degree of the liver damage. Okay, so how damaged is the liver itself? And the intensity of the infection. So how much of the viral load do we actually have? Okay. So here's a good breakdown between A, B, and C. Those are the ones we really want you to focus on. So hepatitis A, those are the labs you're looking for. ALT, AST, ALP, bilirubin, the hepatitis A antibodies. Okay. These IgM and IgG, those actually help determine the stages of inflammation. If they have this IgG, they actually have immunity to hepatitis A. So that means at one point in your life or another, you can have come in contact with it. Okay, you develop an immunity to it. Okay. Pretty interesting. Okay. And then it breaks down into B and C as well. Okay. So take a look at that. That's directly out of your book as well. So if you want to look more at the labs, it's in there.
Did you say that IgM and the IgG, they help determine the level of inflammation?
So IgM helps with determining how much inflammation is within the liver.
Okay.
The other IgG is the one that tells if you have the immunity hepatitis A. So the only way you get immunity, right, is with exposure, right? Your body builds those antibodies. Okay. Prevention. Everyone's gotten probably for this program your hepatitis B vaccine, right? We can draw titers to see if you're still immune to hepatitis B. Right? Has anyone actually had an hepatitis B titer draw? Right. So I've gotten the hepatitis B vaccine more times in my life than I probably should have. Okay, I don't respond to it. My body doesn't build immunity to hepatitis B. Okay, so I've gotten the series twice. Okay, I even got the newer combination, and I'm still not immune. Okay, it just depends on the person. Genetically, some people don't form a response to the vaccine. So would I still be at risk to developing hepatitis B? Right? So I have to be more careful. There's also vaccines for hepatitis A as well. Hep A is 2 doses. Hep B, it says 3 doses, but there's actually the new Recombavax, okay? Or not Recombavax, sorry, the Hepatic vaccine, and it's 2 doses. So, if you don't want to get poked 3 times. Okay. Pretty interesting. Post-exposure, right? How are we going to treat this after we've been exposed? Okay. You can actually get the immune globulins to help fight that infection, that viral infection. And you may also be able to get your hepatitis B vaccine while this is going on. So if you have hepatitis B, you may also be able to receive the vaccine to kind of help prevent that future, along with your body's own immune response. Okay. Everybody following me so far? I think that once I get to immunities, everybody. Right. Immunities are tough. So treatment, what do we want to do? We want to decrease that viral load. Like I said, the amount of exposure and how much of the actual virus that you're getting, right? Your viral load, we want to decrease that. Okay. Reducing the risk of transmission, right? So if you know a patient has hepatitis B, you better be doing all your standard precautions, right? And then reducing liver damage overall. Everyone following the so far? Okay. Medications we can give, this is in your book, page 822. Antivirals. Okay, that makes sense because hepatitis is a virus, right? Interferon, that's another antiviral, but it also suppresses the immune system. And it's an anti-neoplastic, so we need to use really good precautions if you're ever giving any of those types of medications. Hep B, it's entecavir, okay, one of the strongest of our antivirals we can give. Okay, but we want to try to target with this combination therapy. What do I mean by that? So you get your antiviral, but you're also getting something to help with those immune system effects as well. Okay. And then there is acute versus chronic, so your book kind of has it laid out like that. So look at that when you get a chance. Interferon, that's listed here, that's why I didn't go super in depth, is for your acute hep C. Okay, this is going to help try to prevent that chronic hepatitis C. But again, from the video, do people always know when they first get hepatitis C? Not always, right? So it's good to try to catch it early. Okay, and we can give them this interferon, which is IM or sub-Q. It's going to cause some flu-like symptoms. Okay, it's also been linked to cause some depression. The chronic hepatitis C, we're going to talk about the ribavirin. Okay, that one's an oral med. It can cause hemolytic anemia. Okay, so they need to have frequent lab draws. Hemolytic anemia, what kind of lab values do you think we're looking at? H&H, what's the other big one? If the red blood cells are lysing, hemolysis, what's gonna happen to your red blood cell? That's also good, right? So we need to look at all those components. Birth defects, so if someone is pregnant, right, you do not want to give that medication. Okay, if they're on this medication and they're of childbearing age, they should have 2 methods of birth control. Okay, we do not want these patients to become pregnant. Okay. And you'll understand that more in 2030 when we talk about pregnancy and things like that in spring. But early stages of pregnancy are the most important for your fetal development. Okay, so that's why that first 2, that's why we need to prevent those birth defects. Okay. Nursing intervention. So we're going to prevent transmission of the infection. Standard precautions is a big way we're going to do this. I talked about that, right? Proper food handling for your hepatitis A and E, but we talk about A a little more often, right? Hand hygiene is super important. Okay. Prophylactic treatment of household intimate partners. A lot of this can be transmitted with sexual contact, right? So if you're exposed to that, we need to do prophylactic treatment. Okay. And when we diagnose, we need to try to abstain from sexual contact, right? Do patients always listen to us? No. So that's why we do this prophylactic treatment, right? Cover all of our bases. Hepatitis A has to be reported to the health department if they're a child care worker or a food handler. But that makes sense, right? Because we're more at risk to transmit that to others. Okay. Contact isolation if they're fecally incontinent. Okay. Like everybody's worst nightmare. It's like C. diff, but it's A. Right. Sounds kind of funny, but that's one way you might be able to remember. Okay. Other interventions, we need to ensure they have adequate nutrition. Things that are not going to be difficult for you to digest, for your liver to process, right? Do not consume alcohol. Your liver is already stressed. Okay. I can't tell you how many patients come in with hepatitis C, and then you see that their alcohol level is way off the charts, right? And it's like, that's a double whammy to your liver. Okay. Liver toxic agents like acetaminophen, they should not be taking Tylenol, right? So if you see that on your test, you're like, oh yeah, we don't want to give Tylenol to somebody who's already got a liver problem. That makes sense. Okay, because Tylenol is filtered through what? And stressing the importance of rest, right? Because this is an immune issue, right? Our body is going to be working in overdrive. So we need to make sure they're resting, avoiding strenuous activities so their body can rest. Educating on medication administration and preventing cirrhosis is our priority concern. Okay. Does everyone follow me so far? Okay. Cirrhosis, okay. So when we have cirrhosis and when we have fibrosis, which is scarring of the liver tissue, our liver can't do what it needs to do. Okay. Those cells, we've had that hepatocellular failure, right? So we have, over time, a decreased mass of the liver, okay, impaired function, and alterations in blood flow, which we saw from that video, right? So it's a very dangerous thing when we have a patient with liver cirrhosis. And there are different types, okay? I think most commonly, right, we see Linux or alcoholic, chronic alcohol use cirrhosis, right? Progression, so we start with fatty liver, okay? Leading to, they call it alcoholic hepatitis, which is that inflammation to the liver, and further cirrhosis. Okay, so it happens in stages, you just don't drink alcohol and wake up one day with cirrhosis. Right, it happens over time. Okay, because we have to start with our fatty liver, progressing to some fibrotic tissue, and then overall liver cirrhosis. Then we have post-necrotic, okay? So this is where your patient, like in the video, they have chronic hepatitis B or C, okay? And they might not have had symptoms, and all of a sudden, later in life, they realize they have cirrhosis and they start to have those extreme symptoms, okay? Or you might see post-necrotic as your non-alcoholic fatty liver, okay, leading to cirrhosis. Anyone have anyone in their family who has fatty liver and they don't parent, right? So it could be genetic, right? So that can lead to post-necrotic liver cirrhosis. Which is very scary because it's like, what did I do? I didn't do anything wrong. But you still could end up with, bad things happening like cirrhosis to your liver. Okay. Your chronic viral hepatitis is the leading cause of your post-necrotic. Okay, or obesity, which increases the incidence of fatty liver disease. Okay. Biliary, so if our bile flow is obstructed, or if we have an autoimmune disease, this could lead to cirrhosis with elevated liver, bilirubin levels and liver failure and jaundice. Okay. And jaundice is caused by what?
Increased bilirubin in your system.
Right. So we can't excrete it, right? So we have that buildup of bilirubin. Okay. Complications, okay, of cirrhosis. Number one, portal hypertension, but that makes sense, right? That blood cannot be exchanged to the liver. We have buildup of pressure, and then we have portal hypertension. Okay. We talked about, and we saw in the video, how portal hypertension leads to these esophageal varices. Where else can we get varices? What's that?
Legs.
Yeah, legs. Where else in your abdomen area?
Rectum and your umbilical.
Rectum, umbilical arteries, and things like that, right? Because the veins come through there. Portal systemic encephalopathy, okay? Hepatic encephalopathy, and then hepatorenal syndrome, which we talked about. And then spontaneous bacterial peritonitis, yikes. Okay, so that's a spontaneous bacterial infection, okay, in your peritoneal cavity, because remember, ascites, we have that fluid buildup, right? Bacteria gets within the fluid buildup, we're in a bad shape, right? Peritonitis, how do you know someone has peritonitis? Abdomen is what? Swollen. Swollen, and what else does it feel like? Do you remember? Hard, yeah, that's a big characteristic of peritonitis, absolutely. So that is a risk with your cirrhosis, okay? Portal hypertension, here's another picture. So, again, we talked about the procedure, the tips that helps bypass that a little bit, right? Helps shock the blood. Okay, because when we have portal hypertension, we have that congestion that's happening, okay? That congestion leads to peripheral edema, especially in the limbs, okay? Or in the abdomen itself. Okay. Meds, we saw that on the video. We're gonna give propranolol, the beta blocker, because that does what? Controls your heart rate, right? A little bit of your blood pressure, right? So it's gonna help decrease the workload, okay, of what your liver's filtering. Okay. Prevents hypertension and increased pressure. This is a big thing too. It helps prevent varices. And again, one of our last steps there is the TIPS procedure. If they have a TIPS procedure, what are they at risk for then? Increased pneumonia, right? Because our liver is no longer filtering that, so that's still a risk. Okay. Again, the causes of ascites. So if we have pressure in the abdomen, we can't get that fluid to go where it needs to go. Okay. Ascites, the big causes, again, portal hypertension, decreased protein, serum protein, and then increased aldosterone, which we'll get to that. Okay. Abdominal assessment for ascites. Okay, so we talked about this. Shifting dullness to the abdomen. Okay, so if you're doing compression and shifting dullness. There's a fluid wave test. I've actually never done that one. The biggest thing is what we talked about earlier, the abdominal GERD. Okay. because you can trend this day to day. Okay. Let's go ahead, I'm gonna see how long this video is, but we'll go ahead and take a 10-minute break. I'm gonna see if we're gonna. Okay, so go ahead and take a break and we'll come back to it.